Hello everybody. Today we are going to discuss about eCPR. Survival rates after cardiac arrest are low. In this context, the extracorporeal cardiopulmonary resuscitation has been the first introduced as ultima ratio in 1966. After 6 decades later, more than 15,000 eCPR cases are registered into the ESLO registry with survival rate of 30%. We will discuss the background, indication, challenges and limitation of eCPR. Now, rationale for ECP. Approximately 8% of individuals who experience out-of-hospital cardiac arrest survive, with significant variation observed between the different countries and cohort, ranging from 0 to 18%. Survival rate between 15 to 34% have been reported for in-hospital cardiac arrest. One of the dominant predictor of survival is the delay between the arrest and the return of spontaneous circulation. After 15 to 20 minutes of conventional cardiopulmonary resuscitation, the probability of survival with good neurological function is approximately 2%. CCPR achieves a mere 25% to 30% of native cardiac output, leading to progressive tissue hypoxia and ultimately death, which might contribute to this outcome. The duration of CCPR with insufficient circulation is coined low flow duration. The rapid restoration of the perfusion and the oxygen supply to the vital organ plays a crucial role in the chain of survival and the quality of life of patient after cardiac survival. ECPR ensures the sufficient organ perfusion, including brain, in patient without RS. After progressive detonation of prognosis during low flow is resolved, the cause of collapse can be resolved. Now about definition, ECMO and extracorporeal life support are used synonymously in the literature. According to the cannulation, two main operational modes of ECMO are used. That is the veno-venous mode for pulmonary failure and the veno-arterial mode for circulatory failure or ECPR. We will exclusively cover VA ECMO in the context of ECPR. ECPR is defined as VA ECMO cannulation during refractory cardiac arrest. Refractory cardiac arrest is considered as the absence of ROSC despite the provision of appropriate CPR for 15 to 30 minutes. Moreover, eCPR includes the patient with on and off CPR and those without stable ROSC. Since stable ROSC is defined as spontaneous circulation for at least 20 minutes without chest compression and persistent circulation, also VA ECMO cannulation within 20 minutes after ROSC is considered eCPR. Unfortunately, eCPR definition does not specify which part of VA ECMO cannulation has to be completed within 20 minutes after potentially stable ROSC in order to still qualify for eCPR. Only the intention to cannulate and successful puncture of the vessel, placement of the both cannula or running ECMO system. Theoretically, there might be a big difference in the disease severity and outcome between patient with potentially stable ROS and patient with the truly refractory arrest. Insufficient clarity in defining eCPR hinders the comparability of the scientific studies, introducing potential bias. Accordingly to the Einstein definition, the placement of VV ECMO during CPR is not considered eCPR. Now about ECMO system. The ECMO system consists of 6 integral components: the cannula of the vascular access, line, pump, oxygenator, heat exchanger, and interface. Many different cannula are commercially available, which differ in the handling and the technical feature. For VA ECMO, typical draining cannula range from 21 to 27 French, while returning cannula are smaller and shorter. The draining cannula is connected to the pump. For adult, mostly centrifugal pump are used to circulate patient's blood through ECMO and to provide pressure necessary to maintain constant blood flow throughout the ECMO system and back to the patient. Next in line is the oxygenator. Oxygenator consists of semi-permeable membrane that allows gas exchange to occur. This core component of ECMO circuit is responsible for enriching oxygen and reducing carbon dioxide in the patient's blood. Last part of the VA ECMO circuit is the arterial cannula. In order to avoid accidental hypothermia and for targeted temperature management, heat exchanger is connected to the circuit. Finally, the ECMO is controlled by interface to provide feedback to the healthcare team. The oxygenator mimics the lungs gas exchange function while the pump provides up to 6 liters per minute blood flow. The maximum blood flow is the contingent upon the choice of cannula, where smaller cannula impose higher resistance, resulting in the higher shear stress and the lower ECMO flow. The transfer of oxygen and the carbon dioxide within the oxygenator can tailor to the patient need by adjusting the sweep gas flow and its oxygen concentration. In VA ECMO, in VA mode, ECMO can functionally approximate full cardiopulmonary bypass by providing retrograde mechanical circulatory support. About cannulation in general, two cannulation techniques are employed, that is central and the peripheral. For central cannulation, sternotomy is required in order to place cannula directly into the right atrium in the ascending aorta. Compared to this highly invasive approach, the peripheral cannulation is far less invasive. In literature, similar neurological outcome, mortality, and peripheral ischemia were reported compared to the central and the peripheral cannulation, while bleeding complications were more frequent in the central cannulation. Since peripheral cannulation does not require sternotomy, is more readily available and thus practically the only applied technique in an eCPR scenario. In the three large randomized control eCPR trial, peripheral cannulation was used. Specifically, large bore cannula are introduced through the patient's groin vessel, that is common femoral vein or common femoral artery, with their tip position in the superior vena cava, either aorta and common iliac artery, respectively. The procedure is commonly performed percutaneously under sonographic guidance using Seldinger technique. In some cases, fluoroscopy may be employed for the further resistance, particularly when the procedure is conducted in the cardiac catheterization lab. Surgical cut down is also an option, usually not used as first line approach. To drain venous blood, 21 to 27 French cannula is ideally extended to the superior vena cava as uterus. This cannula has a large opening at its distal end and the numerous side openings, allowing it to draw blood from the considerable portion of the upper and the lower vena cava, as well as from the right atrium of the patient. The returning arterial cannula typically has 15 to 19 French and return the blood to the patient retrograde. The entire cannulation and the connecting process takes approximately 10 to 15 minutes for the experienced team. Now about patient selection. Criteria for the eCPR: age less than 70 years, witness cardiac arrest, time from arrest to CCPR is less than 5 minutes. The initial cardiac rhythm, ventricular fibrillation and pulseless ventricular tachycardia, pulseless cardiac activity. Time from arrest to the initiation of the ECMO flow is that is low flow interval is less than 16 minutes. End tidal carbon dioxide of more than 10 mmHg during CCPR prior to the ECMO. Intermittent ROSC and the recurrent ventricular fibrillation. Presence of signs of life during CCPR may predict the survival. Absence of previously known life-limiting comorbidity, that is end-stage heart failure, COPD, end-stage renal disease, liver failure, terminal illness, and alignment with the patient's care goal. Not no known significant aortic valve incompetence. Now the low flow. The likelihood of the good neurological survival diminishes rapidly during CCP. In eCPR, survival likewise decline along the duration of prior CCPR, but survival rates are higher, up to 30% at 20 minutes, 10 to 15% at 60 minutes. Low flow duration is arguably the most critical determinant of outcome, showing an almost linear relationship. This led to commonly acceptable paradigm that eCPR should be performed early and best within the golden hour to reduce the low flow and improve the outcome. Many steps are typically required between collapse and ECMO flow. So we'll discuss subsequently that we'll discuss the subsequently. Recognize the importance of short low flow, and the focus of effective eCPR program is on refining the process towards the minimizing low flow. Cannulation itself take 10 to 15 minutes for well-trained team. Such a fast cannulation can only be achieved in the environment optimized for eCPR. In recently published Inception study, notable for this, its high world relevance. Median interval from hospital arrival to the start of cannulation was 16 minutes and duration of cannulation of 20 minutes. The intricacies of the each emergency system and hospital may take it challenging to establish universally applicable eCPR algorithm. Considering the diverse operational framework of emergency system and healthcare facilities across different countries and regions, localized efforts are essential. Analogous to the time benchmark set for STEMI, where interval from the door to balloon insertion served as quality control, and similar principles should be applied to the ECP. Now, the time under low flow ECPR, time under resuscitation observed into the RCTs are given. So, three RCTs are compared, that is arrest, Prague, out of hospital, cardiac arrest, and inception. So, three RCTs examine the role of eCPR in patient following out of cardiac arrest. Here, time plays a crucial role in eCPR as prognosis was strongly correlates negatively with the low flow duration. So three primary interval in the refractory out of cardiac arrest, that is time on the scene, then time required during transportation, and the time required for cannulation are present. Delays are attributed to one of these three main aspects of eCPR, that is, time on scene, transportation, cannulation are not shown. It is worth noting that arrest and the Prague out of hospital cardiac arrest were a single were these trials were a single center trial, and the inception was the multi-center trial. Now about timing of the eCPR. The the reciprocal correlation between outcome and the duration of the CPR has been discussed earlier. Cutting down on the low flow duration by beginning cannulation for eCPR earlier therefore seems intuitive. During eCPR too early, however, carries the risk that patient without refractory arrest would undergo unnecessarily and highly invasive treatment. Numerous efforts have been taken to identify optimal transition time point from CCPR to eCPR. Different emergency medical service systems are employed across the international context. While some regions prioritize stay and play approach, others emphasize scoop and run strategy. Data from the US showed that there is no benefit in the stay and play strategy beyond 15 to 20 minutes of CCP. However, survival improves when transporting the patient while resuscitation continues. These observations aligned with the studies suggesting 12-minute threshold for transition from CCPR to eCPR. Establishing a swift transition from conventional to eCPR requires overcoming logistical challenges in order to minimize low flow stage. So this is the figure which shows the eCPR scenario and distance out of hospital cardiac arrest to the eCPR center. So we can compare the this low flow time on a load and go was 40 minutes. On-site cannulation low flow time was 80. Residuous at initiation hospital, the low flow time was 50. So these are the challenges in the eCPR. That is patient selection. So first challenge was the patient selection. So there were the particular criterias. So on that group only we can initiate eCPR. So these criterias were age less than 75 years, bystander eCPR, shockable rhythm, Then short low flow duration, incomplete information, professional CPR teams, and the availability of the eCPR resources. Then there were logistic challenges like integration of the ECMO center and where to can. Then on ICU, challenges were faced as trained staff, bleeding, transfusion, thrombosis, and 24/7 availability demand. Then eCPR transition, that is availability of eCPR resources, transition at minutes 15, preclinical integration of eCPR team. Then complications like cannot cannulate, CPR associated trauma, leg ischemia and bleeding. Then ethical complications like ethical dilemma, care is stressed to the team, and neuroprognostication. On ICU, the care for patient after eCPR is resource intensive, incurring high cost and the requiring substantial personal involvement. Many patients die within the first day after initiation of ECPR. The mortality of up to 70% in the ELSO registry despite eCPR can be particularly burdensome for attending physician and nursing staff. Consideration should also be given to the stress experience by the patient's relative. And the initial care on the ICU includes the standard post-resuscitation care, ECMO maintenance, and the prevention and treatment of complications. Crafting patient-centered individualized therapy for critically ill eCPR cohort presents formidable challenge even to the experienced team. Ethical issues are commonly reported in the context of ECMO therapy. In-depth discussion of ICU treatment is beyond the scope of this discussion, but eCPR is currently not routine procedure, but rather last resort treatment option for selected patients in situation where eCPR is available. Generally, ECMO therapy is used as bridge to recovery where when there is hope or expectation for the patient's improvement, or in cases of irreversible organ failure as a bridge to organ transplantation or implantation of durable left ventricular assist device. After eCPR, about third of patients die of anoxic brain injury. Organ donation is possible in cases of the brain death, yielding the same result as conventional organ donation. In some countries, organ donation is feasible after circulatory death. In such a cases, the organ retrieval can occur after cessation of the life-sustaining ECMO support for defined period, that is 5 to 15 minutes, during which cardiac arrest persists. Now about complication, eCPR is highly invasive intervention. Beside complication associated with the CCPR, such as fractures, tube displacement, hemo and pneumothorax, there are specific short-term complications unique to the ECPR. These include access site bleeding, cannula misplacement, primarily arising from cannulation process. Other typical complications I will be discussing below. The coagulation. During ECPR, attention is crucial for thrombotic complication, hemolysis, and bleeding event. These issues arise from the disturbance in the coagulation due to patient's blood contact with ECMO surface or mechanical stress. Undoubtedly, this is one of the most underestimated complications of ECMO therapy, which demands persistent vigilance and appropriate allocation of resources. Then ischemia. The arterial cannula may occlude the lumen of the femoral artery in which it is inserted, leading to the distal ischemia. To avoid ischemic damage in the perfusion area, an additional cannula should be introduced antegrade into the femoral artery. Typically, the common femoral artery or superficial femoral artery, distal to the puncture site of the arterial cannula and connected to the returning ECMO cannula. This way, oxygen-rich blood is directed to the peripheral blood vessels of the lower limb. If routinely used, antegrade leg partial cannula improves outcome is debatable as there inherent risk of the access site bleeding. Recent data suggests that bilateral cannulation with arterial and the venous cannula placed on the opposite side may lead to the reduced complication, including lower rate of bleeding, decreased need for the vessel repair, and decrease in hospital mortality. Now selective perfusion. Inserting the arterial ECMO cannula into common femoral artery, resulting in the non-physiological reverse laminar blood flow. The Harlequin syndrome, it is the characterized by the hypoxia in the upper half of the body despite sufficient oxygenation in the lower. In the context of VA ECMO support during eCPR, poorly oxygenated blood from the lung can enter the left ventricle and then flow into the aorta to the lung failure. Inadequate oxygen supply can lead to ischemic brain injury or brain damage or ischemic myocardium. The location of this watershed depends on the volume status, cardiac ejection performance, blood flow rate of ECMO system. Determining the exact location of the watershed is often challenging in the clinical practice. To monitor cerebral oxygenation, pulse oximetry of right upper extremity should be performed to exclude cerebral hypoxia. Additionally, near-infrared spectroscopy can be used to assess cerebral tissue oxygenation and provide early indication of insufficient cerebral oxygen supply. Now about cardiac function. Contemporary post-resuscitation guidelines are primarily derived from studies involving non-ECMO patients. Consequently, hemodynamic management typically emphasizes the traditional parameter, including blood pressure, venous saturation, and lactate level rather than the blood flow. VA ECMO, however, primarily supports the circulation by adding blood flow of up to 6 liters per minute to the native cardiac output. Quantifying the native cardiac output can be challenging as a several specific points in hemodynamic monitoring of the patient on VA ECMO have to be considered. Furthermore, by draining blood, preload of the right ventricle might be reduced and endogenous cardiac output might be decreased. The high blood flow and the pressure in the aorta increases the afterload and the left ventricle along the mean arterial pressure. In cases of cardiac failure, the left ventricular function may be impaired to the extent that it cannot sustain adequate cardiac output under this condition, leading to pulmonary congestion and in cases of stasis intracardiac thrombosis. To counteract this, the measures for left ventricular unloading should be considered whenever intrinsic cardiac output is deemed insufficient. The most common method used beyond the application of inotropic and inodilator medication for adjusting afterload for this purpose are IIPP and Impella device. The indication for this intervention are challenging and there is currently no definitive data on the optimal timing and the type of procedure necessitating careful evaluation on case-by-case basis. The recruiting unload ECMO trial might shed light on this field. In the context of the previously described Harlequin syndrome and the concomitant lung failure, it may be necessary in an individual cases to expand VA ECMO system to VVE system before implementing left ventricular unloading device to ensure sufficient oxygenation of the blood in the left ventricle. Now, the post-resuscitation syndrome. In addition to the above discussed organ system, all other organs have been subject to the ischemia reperfusion injury leading to multi-organ failure. The whole body ischemia syndrome is the heterogeneous and requires patient-centered symptomatic therapy according to the presentation. Organs that typically need support are lung, vasoplegia, and kidney. Now about clinical evidence. The first published randomized trial on the eCPR was ARREST trial, published in 2020, demonstrating the striking 43% good neurological survival in eCPR group compared to 0% in no eCPR group. At first glance, this seems plausible since survival strongly declined with longer low flow duration after out of hospital cardiac arrest and intra hospital cardiac arrest. Importantly, however, mortality without eCPR in selected patients with witness cardiac arrest, immediate CCPR, younger age, shockable rhythm, treatable cause of arrest, even longer low flow duration is not 100%. It is no coincidence that predictor of the better outcome in CCPR are considered go criteria for eCPR. Two larger randomized trials, including well-selected patients, could not demonstrate superiority of the eCPR. While data from the propensity score match registry reported conflicting results, new meta-analysis of randomized trials suggest improved survival. Ultimately, more data will be needed to prove benefit of eCPR and to identify patients more likely to profit. So this is the trial which was published in NEJM, that is in the extracorporeal life support in infarct-related cardiogenic shock. In patient with acute myocardial infarction complicated by cardiogenic shock, was planned early revascularization. The risk of death from cause at 30-day follow-up was not lower among the patient who received the extracorporeal life support therapy than among those who received the medical therapy. Thank you, guys.